Hello everyone. Okay, today we will be discussing the post-op pyrexia, the ganglion, and the DVT, that is the venous disorders, and the varicose vein. Okay, so starting from our first topic of today, that is post-op pyrexia. Mm, okay, what are the important points to learn about the post-op pyrexia? These are causes of post-op pyrexia, and what are the important points you will ask from the patient, and what are the investigations and managements for post-op pyrexia. So, by definition, we have post-op fever is defined as temperature greater than 38 degrees C, that is 100 degree Fahrenheit, or on two consecutive post-op days, or greater than 39,102 degree Fahrenheit on any first day of post-operation. Whenever there is fever in post-op period, check for white W's and V's. Okay, this is the mnemonic. You have to check for W's and V's. What are the W's? These are wound, wind, water, and wandering drugs. Okay, so for the wound we will check the discharge and pus and infection. And for the wind, we will check for atelectasis, crepitations, and chest infections. And for the water, we will check the UTI, that is for 5 to 7 days, and catheters. And the wandering drugs, we will check the drugs, that is the administration of the drugs, that is antibiotics, and given and change if necessary. So these are the four W's. Now the four V's are vessels, that is for 7 to 10 days we have to check for the DVT and for the thrombophlebitis. Okay. So this is the definition of the post-op pyrexia, and what are the four W's that we will check, and what are the V's that we will check. Okay. Now what are the other causes? The other causes are of post-op pyrexia are wound dehiscence, indwelling catheters, abscess, drugs, transfusion reactions, infections, intravenous line, pneumonia, and atelectasis. These are the other causes that can cause post-op pyrexia. What are the investigations options that we will do? These are chest X-ray is done, ABGs, arterial blood gases, sputum culture is done, urinary and culture is done for UTI and other infections. Food blood count is done for any infections. ECG and echo is done. Blood culture is done. Serum D dimer is done, and duplex scan is done. Chest X-ray is done for pneumonia and atelectasis especially. What are the management options of post-op pyrexia? First of all, we have to treat the cause of post-op pyrexia. For example, if it is due to abscess, then we have to treat that. If it is due to catheters, we have to treat it. if the cause is infection, then we have to treat it. So first treat the cause of the post-op pyrexia, then O2 inhalation, antipyretics, intravenous fluids are given, broad spectrum antibiotics are given, good analgesics and breathing exercises are done. These are the general measurement. Okay, so what we have discussed we have discussed that what is the post-op pyrexia, and then we have discussed the four W's of it, that we will be checking for the post-op pyrexia, then the vessels, and what are the other causes, and then we started the investigation that are done to find the diagnosis of post-op pyrexia, and then we discuss the management. Now coming towards ganglion, what is ganglion? It is a painless cystic swelling on dorsum of okay, we are having a scenario that describe that there is a painless cystic swelling on dorsum of her wrist. We are having a patient and there is painless cystic swelling on dorsum of her wrist for 1 year. Pain increase and lump increase, ache of wrist while working on computer. Okay, so diagnosis is asked, what are the physical signs, and where is the cyst found, matlab what are the common sites of ganglion, and what is the prognosis, and what is the treatment option. Okay, so the definition is it is a cystic degenerative swelling arising from a tendon, sheet or joint. What is ganglion? It is a cystic degenerative swelling arising from a tendon, sheet or joint. It grows slowly and most commonly occurs between 20 to 60 years of age. It can occur anywhere, but most common sites were the dorsum of wrist and radial aspect of wrist. These are the most common sites of ganglion. What are the physical signs? The physical signs are check the skin overlying cyst, then consistency, it is soft or smooth, and then tenderness, it is non-tender. The fluctuation test should be positive in ganglion, and trans-illumination test is negative in the case of ganglion. What are the common sites? The common sites for ganglion are the dorsum of hand and on the foot or dorsal or lateral aspect, small ganglion in relation to the flexor of finger. What is the treatment option for ganglion? It is Asymptomatic ganglion, better left alone. If it is asymptomatic, then it will heal itself. For symptomatic aspiration of ganglion, an injection of sclerosant may reduce the size, that is corticosteroids. Surgical excision can be done under general anesthesia in bloodless field with help of tourniquet, and prognosis recurrence rate is high of ganglion. Okay, so we have discussed this small topic: what is ganglion, what is its definition, what are the physical signs, what are the common sites, what are the treatment options. Okay, now coming towards the DVT, which is important and major topic in the field of surgery and also in the other field, that is medicine, etc. So DVT is a venous disorder. We have a scenario which says that leg swelling to mid thigh is present, slightly rise in temperature, post of fifth day, erythema of skin, no trauma history, calf form and tender to touch, foot pulse is normal. Okay, dialysis patient, sudden swelling in foot. The second scenario is we have a dialysis patient and he is having sudden swelling in foot. So first of all, you should remember that the DVT, that is deep venous thrombosis, is common in the bedridden patients and the dialysis patient. So if you want to diagnose the disease, then the hint of this thing will be present, that the patient is a post-op patient or he is on dialysis. The diagnosis, investigation, differential diagnosis and treatment is asked. What are the risk factors and what are the long-term sequelae or complications of DVT? So we will discuss this one by one. First of all, coming towards the definition, what is DVT? Term thrombosis refers to formation of abnormal mass of blood within vascular system of living. When the same occur in deep veins, it is referred to as deep venous thrombosis. Okay, this is the definition, that it is a type of thrombosis that form due to abnormal mass of blood. What are the causes of DVT? There are three main causes, also known as Virchow's triad. The first one is endothelial injury. For example, hypertension, endotoxins, and smoking. This causes the endothelial injury, which causes the DVT. The second number is stasis or turbulence of blood flow, for example, cardiac arrhythmias and aneurysm, etc. The third one is blood hypercoagulability. For example, antithrombin 3 deficiency and protein C or S deficiency lead to hypercoagulability, which can cause DVT. So these are the main causes. What are the risk factors of thrombosis? So you should remember this mnemonic. Thrombosis, 40 is trauma, H is hormones, R is road traffic accidents, E is operations, M is malignancy, B is blood disorders, O is obesity, I is immobilization, and S is splenectomy. These are the most common risk factors for DVT. What are the clinical features with which the DVT patient will present? It is swelling, pain or redness, erythema, dilated superficial veins, low-grade fever with increased pulse and calf tenderness. Now, what investigations we will do for the patient of DVT? We will do the duplex ultrasound for diagnosis, venography, dye is injected in dorsal wheel and X-ray is done. This is venography. D-dimers is done, blood for clotting factor is done, CT or MRI is done, antithrombin 3 factor is checked, and protein C and S and factor 5 is checked for hypercoagulability. Now, what are the differential diagnoses of DVT? These are ruptured backyard cyst, cellulitis, case gangrene, or calf muscle hematoma. The same features may appear in the following disorders. So these are the differential diagnoses of DVT. Now, what are the treatment options? We have conservative treatment and specific treatment. In conservative treatment, we will elevate the limb, we will do the elastic compression, and we will give the analgesics. For specific treatment, we will give the anticoagulants, and the anticoagulants that are given are heparin, given according to the weight of the patient, and 10K unit bolus, 30K to 40K intravenous is given. The second one is venous thrombectomy. A load can be removed by opening femoral vein and incision in groin, removing all clots. Okay, so clots can be removed by opening femoral vein by incision in groin, removing all clots. The third one is thrombolysis. Catheter is passed and streptokinase is infused to cause thrombolysis. Streptokinase causes thrombolysis, so through catheter it is infused. And the prevention of pulmonary embolization, insertion of inferior vena cava filter can prevent pulmonary embolization. Okay, so what are the treatment options? Conservative and specific. In specific, we have anticoagulants, venous thrombectomy, thrombolysis, prevention of pulmonary embolization. What complications can occur due to DVT? It is shortness of breath, fainting, rapid breathing, anxiety, irregular heartbeat, and chest pain. Okay, so we have discussed the deep venous thrombosis, the main topic of surgery, and in this scenario, we have the history of a post-op patient and a dialysis patient, and the clinical features are swelling, pain, redness, erythema, dilated superficial veins, and low-grade fever. So we have discussed the definition of DVT. Then we discussed the causes. The main three causes are endothelial injury, stasis or turbulence, and blood hypercoagulability. Who or which patients are at more risk? Then the risk factors are that we can memorize it from the pneumonic thrombosis, such as trauma, hormones, road traffic accident, operations, malignancy, blood disorders, obesity, immobilization, and splenectomy. Then we will do the following investigations, and the differential diagnosis are ruptured backyard cyst, cellulitis, gas gangrene, and calf muscle hematoma. The treatment options are divided into two major classes, that is conservative and specific. In conservative, we will elevate the limb and elastic compressions are applied and analgesic is given, while in specific, the anticoagulants, venous thrombectomy, thrombolysis, prevention of pulmonary embolization is done. The complications are the following. Now we will go for the varicose vein. What is the scenario? We are having pain in right leg on prolonged standing, noted distended veins on that leg for past 2 years, dilated tortuous vessels on legs. What is the diagnosis, investigations, treatment, complications, and how will you assess? So the definition of varicose vein is: varicose veins are defined as dilated tortuous veins, subcutaneous veins, often palpable, greater than 3 mm in diameter, measured in upright position with demonstrable reflex reverse flow of blood. So varicose veins are defined as dilated tortuous veins, subcutaneous veins, often palpable, greater than 3 mm in diameter, measured in upright position with demonstrable reflex. What is the examination? How we will do the examination for varicose vein? We have Trendelberg and tourniquet test for elevation of perforators. Evaluation of perforators. Then we have Perthes test for evaluation of patency of deep veins. Then we have cuff impulse test, and then we have Morrissey test. These are the main tests for examination of the varicose vein: Trendelberg, Perthes, cuff impulse, and Morrissey. Okay, what are the investigations options? We will do the CBC, the coagulation profile, the varicography, that is gold standard for the varicose vein. We will do the Doppler ultrasound, that is to exclude arterial diseases and to determine the patency. We will do the duplex scan, vascular anatomy and direction of flow can be measured. We will do the venography, contrast X-ray of veins is obtained. We will do the photoplethysmography and MRI. Then we will do the assessment of the patient. History is taken, any trauma, DVT or occupation or lack of exercise. Examination is done, inspection of the legs and the thigh, the compare shape of leg, then observe skin changes, venous ulcers, eczema and pigmentation, any dilated veins in lower abdomen, ankle flare, site, palpate for locality of the thrombosed vein, temperature and tenderness, palpate whole length of the vein. This is the general examination for the varicose vein. The clinical examination is Trendelberg test, tourniquet test, Perthes test, cuff impulse test, and Morrison's test. Okay, what are the treatment options for the varicose vein? We have the general treatment and the surgical treatment. In general treatment, we will graduated compression stock, the cover entire thigh or can extend below knee. Then injection sclerotherapy, that is blood is removed from the vein and sclerosing agent is injected into the vein and compression bandage is applied. Microsclerotherapy is done, injecting diluted sclerosing agent. This is the general treatment of the varicose vein. For surgical, we will do the Trendelberg operation, then subfacial ligation, subfacial ligation of cocket and rod, and the phlebectomy. And new surgical approach is V and US closure and Trivex closure. Subfacial endoscopic perforation surgery is done, strapping can be done, and Lontoin's vertical approach can be done. What are the complications of the varicose vein? Bruising and discomfort can occur, injury to the sensory nerve, saphenous nerve, sural nerve, and to avoid injury to nerve, long saphenous veins should not be removed below mid-calf level, and great care should be exercised in removing below mid-calf level, and great care should be exercised in removing short saphenous vein. Motor nerve injury and venous thrombosis. These are the complications of the varicose vein. So what we discuss in the varicose vein, we are having the 7 scenario which describe the clinical features of pain in the right leg on prolonged standing, noted distended veins on that leg for past 2 years, dilated tortuous vessels on the legs. So this is varicose vein. The diagnosis, investigation, treatment, complication and assessment is asked. We will first define the varicose vein. Then the examination is done. For examination we have 4 main tests. There is Trendelberg, Perthes, cuff impulse, and Morrissey test. In investigations we will do the CBC, the varicography, Doppler ultrasound, duplex scan, venography, photoplethysmography, and MRI. Then we will do the assessment of patient. For assessment, first we will take the history, then we will do the examination, then we will do the clinical examination, then we will provide the treatment. In treatment, first the general treatment is provided, that is the graduated compression stroke, then the injection sclerotherapy, then the microsclerotherapy, then the surgical interventions are done, and then we have discussed the complications of varicose vein. In the next section, we will be discussing the cervical lymphadenopathy. Okay, now coming towards cervical lymphadenopathy. So let's read the scenario. In scenario, we are having a lump which is supraclavicular in region and which is 7 into 7 centimeter in size, firm, mobile, in weakness. Diagnosis, causes, investigation, and complications of surgery are asked. These are the important things that we have to learn about the cervical lymphadenopathy. So let's define cervical lymphadenopathy. It refers to the lymphadenopathy that is abnormal size and consistency of the cervical lymph nodes. Okay, what is cervical lymphadenopathy? It refers to the lymphadenopathy that is abnormal size of the cervical lymph nodes. Now, what are the causes? These are acute infection, chronic infection, malignancy, and sarcoidosis. These are the main causes of the cervical lymphadenopathy. In acute infection, we are having viral hepatitis virus, human immunodeficiency virus, and bacterial virus, that is Staph aureus and streptococci. In chronic infection, we have TB, actinomycosis, brucellosis, and toxoplasmosis, while in malignancy, we have lymphoma, squamous cell carcinoma, and sarcoidosis. Now, what are the differential diagnoses? Differential diagnoses are enlarged lymph nodes, lipoma, cold abscess, TB, lymphoma, cystic swelling, hemangioma, subclavian artery, and aneurysm. These are the differential diagnoses of cervical lymphadenopathy. Now, what investigations we will do? We will do the CBC for leukocytosis, the blood culture, the culture of pus if present, and raised ESR is checked, biopsy of lymph nodes is done, and CT and MRI is done. Now, what are the complications if removed by surgery? Then numbness can occur, rupture can occur, infection can occur, sepsis, fistula, sloughing of skin over the axis, or seroma and nerve injury and recurrence. This can occur due to the cervical lymphadenopathy. So what we discuss in the cervical lymphadenopathy? First we discuss its definition, that what are the causes, then we discuss the differential diagnosis, then in the investigations, and then the complications which can occur due to if it's removed after surgery. Now, coming towards tubercle lymphadenitis, let's study the scenario first. We are having painless swelling on right side of neck, in posterior triangle of the neck, near supraclavicular area, with slight discharge of pus. Now the diagnosis is asked, the differential diagnosis of lump in the posterior triangle of the neck, the investigations, and the treatment. In scenario, also multiple swellings in posterior triangle of the neck or enlarged cervical lymph node. In the scenario, a clue like this is given. Okay, what are the clinical features? The clinical features are matting, non-tender cervical lymph node, firm, discrete in triangle of neck, mobile, and enlarged lymph nodes. Now, what are the causes of tubercle lymphadenitis? These are acute infection, malignant or chronic infection, and sarcoidosis. What are the differential diagnoses? The differential diagnoses are that of lump, which are discussed here, that is enlarged lymph nodes, lipoma, cold abscess, TB, lymphoma, cystic swelling, hemangioma, subclavian artery, aneurysm. Okay, what investigations we will do for the tubercle lymphadenitis? We will do the CBC, that is HB will be low, ESR will be raised, chest X-ray is done, sputum for FB is done, fine needle aspiration is done, which can give the diagnosis in 75% of cases. Lymph node biopsy shows central secession surrounded by epithelioid and giant cell, and Montex test may be positive. Okay, what is written here? Okay, these are the signs that we can diagnose the cervical lymphadenitis, that is tuberculous lymphadenitis, that is right side of neck, it is present on the right side of neck, supraclavicular it is present, pus discharge is present, multiple swellings in the posterior triangle of the neck is present, it is slowly growing, and it is fluctuant. Okay. Now, coming towards the origin and natural history of the TB cervical lymph nodes, this is in 80% of cases, mycobacterium passes through the tonsillar crypts. Tonsillar nodes are jugulo-digastric group of nodes in the neck. In 20% of cases, lymph nodes in posterior triangle and due to involvement of adenoids. Rarely can spread from tuberculosis tuberculosis of apex and can cause enlargement of supraclavicular and other lymph nodes in neck, that is periauricular, can also be affected. Okay, in 80% cases, myobacterium passes through tonsillar crypts, tonsillar nodes, or jugulo-digastric group of the nodes in neck. In 20% lymph nodes in posterior triangle, and due to involvement of adenoids, rarely can spread from tuberculosis of apex and can cause enlargement of supraclavicular and other lymph nodes. Now coming towards the differential diagnosis of tuberculum lymphadenitis, these are branchial cysts called abscess, HIV with lymph node involvement, lymphomas, and non-specific lymphadenitis. What is the management option? We will take the history of the patient, then we will do the examination, that is general physical examination of the lump, and then we will do the investigation. What are the treatment options? The first is anti-tuberculous treatment. After confirming the diagnosis, the 3 drugs regimen, that is isoniazid, rifampicin, and pyrazinamide is given for 2 months, followed by INH and rifampicin for another 4 months. Okay. Now role of surgery. The role of surgery is first of all, biopsy is taken for lymph node biopsy, and then aspiration is done, aspiration of abscess, and sent pus for FB staining. Then excision of the lymph nodes if persist in spite of anti-tubercular drugs, and then excision of the sinus wall along with the tract. What are the stages of lymphadenitis? These are stages of lymphadenitis common in young adults, that is 20 to 30 years. Upper anterior cervical nodes enlarged, non-tender, discrete form lymph nodes mobile. What are the stages of periadenitis or mating? Results due to the involvement of capsule nodes move together, form non-tender. Mating is pathognomic of TB lymphadenitis. What are the stages of cold abscess? This occurs due to caseating cheesy necrosis of lymph node resulting in fluctuant swelling in neck. Present is no local rise of temperature, no tenderness, no redness. Soft cystic fluctuant swelling is present and negative transillumination test. No redness is present. Okay. On sternocleidomastoid, contract test became less prominent, indicating that it's deep to deep fascia. Okay. Now what is the treatment for cold abscess? Non-dependent aspiration using a wide bore needle, and because caseous material is thick and to avoid persistent sinus. Anti-tuberculous treatment is provided. No incision drainage as it can lead to persistent tuberculous sinus. Stage of colon and stud abscess. It results when cold abscess ruptures through the deep fascia and forms another swelling in subcutaneous plane which is fluctuant. Cross fluctuation test is positive and treatment is same as for cold abscess. What are the stages of sinus? Sinus is a blind tract leading from surface down into the tissues. It occurs when collar stud abscess ruptures through the skin, common in young females and can be multiple. What is the treatment option? Excision of the sinus wall along with the tract. Okay, so what we have studied? We have discussed the cervical lymphadenopathy and its definition and causes, then the differential diagnosis, then the investigation, and then the complication which can occur due to its removal. Then we discussed the tuberculous lymphadenitis, its scenario, what are the causes, what are the differential diagnosis, what are the investigations, then what is the origin and natural history of TB cervical lymph nodes, then the differential diagnosis of the tuberculous lymphadenitis, then the management options, then the treatment. The treatment is anti-tuberculous treatment, and what is the role of surgery. Then we discuss the stages of lymphadenitis. These are the stage of periadenitis or mating, the stage of cold abscess. Then we study or discuss the treatment for cold abscess. Then we study the stage of colon and stud abscess, and then stages of sinus, and then the treatment options. Now coming towards the pneumothorax. Okay, let's change the color of our highlighter so that we doesn't get bored. Okay, pneumothorax. What is the scenario? In the scenario, we are having 43 years road accident. Heart rate is 118 beats per minute. BP is 90 per 60 mm of Hg. Respiratory rate 38 beats per minute. And trachea deviated to the right side of the chest. Left side of the chest is hyperresonant to percussion. Now trachea deviated, then tension pneumothorax. If not deviated, then it is simple pneumothorax. If it is given in the scenario that we are having the deviated trachea, then it is tension pneumothorax. If the trachea is not deviated, then it is simple pneumothorax. Now what is pneumothorax? It is the leakage of air into space between lung and chest wall, pleural space. It can be simple pneumothorax, open pneumothorax, or tension pneumothorax. Now what are the etiological factors for pneumothorax? These are chest injury, blunt or penetrating, lung disease, that is severe asthma, pulmonary fibrosis, and ruptured air blisters, and tobacco. These are the etiological factors for the pneumothorax. Now what is open pneumothorax, simple pneumothorax, and tension pneumothorax? Let's differentiate it. Open pneumothorax is free communication between atmosphere and pleural space either through lung or through chest wall. It occurs with thoracic firearm injuries and stab mounts. What is simple pneumothorax? Small simple pneumothorax does not need any treatment. A repeated chest x-ray after 12 to 24 hours is essential to confirm that it's not progressing. What is tension pneumothorax? It is the deviation of trachea, life-threatening condition caused by air within the pleural space, that is with pressure displacing mediastinal structures and compromising cardiopulmonary function. What are the clinical features for tension pneumothorax? These are clinically diagnosed. Tachycardia and tachypnea and hypotension is present in caused veins. Trachea shifted to opposite healthy side and affected side of chest have no movements. Affected side hyperresonant on percussion and absent breath sounds on affected sides in the tension pneumothorax. Okay, in these are the management options. In open pneumothorax, open wound management and primary survey is performed. The problem is identified and dealt in breathing part of it. Initial management of open pneumothorax is what swelling wounds are dressing tapped on to achieve fluids mechanisms to prevent the respiratory compliance during respiration due to negative intrathoracic pressure. Dressing is done. It prevents from the entering thoracic cavity during respiration, increases the thoracic pressure, pushes air outside to open side of dressing and valve-like mechanism. In simple pneumothorax, we will follow the ATLS guideline and observation is done if small needle decompression is done, respiration, test tube insertion and surgery. In tension pneumothorax, it is emergency vital stability, O2, BP, respiratory rate and pulse is managed following ATLS guidelines. In primary cerebral and resuscitation, injury is picked and management in deep breathing part of it. Immediate needle compression, needle thoracocentesis in second intercostal space in mid-clavicular line while patient is sitting, gush of air is escaped from the needle. These are the management options. This is very easy and simple way of managing the open pneumothorax, simple pneumothorax and tension pneumothorax. If you want to study it in detail, then you can go for the book. Okay. In open pneumothorax, what is open and what is tension? In open, history of penetrating thoracic trauma and opening sucking thoracic wound, tachypnea, increased respiratory rate, trachea is central, breath sounds are absent on affected side, respiratory movement is decreased, hyperresonant on percussion. While history of intention, there is history of blood injury, decreased BP, decreased respiratory rate, increased heart rate, trachea move to normal side, breath sounds are absent on affected side, no respiratory movement on affected side. Okay, now coming towards the hemothorax, we have already discussed the pneumothorax. What we discussed in the pneumothorax, first of all, we discussed the scenario, then what is the definition, then what are the causes of the pneumothorax, then we discussed the open pneumothorax, simple pneumothorax and tension pneumothorax, then what is open and what is tension. Now coming towards the hemothorax, what are the clinical features? The clinical features are same as that of the pneumothorax, but there is a presence of blood. Presence of blood in pleural space is called hemothorax. What are the causes? The causes are trauma. Blood greater than 1500 of ml is defined as massive hemothorax, while in intercostal arteries or memory arteries are involved. What are the management for the pneumothorax? During primary survey, it is evaluated and dealt in deep breathing part of primary survey and resuscitation. Blood is evacuated from the pleural cavity by putting chest tube. Volume replacement with help of colloids and blood is performed. Auto transfusion is considered by a trained thoracic surgeon if the indications are present. More than 1500 ml blood after insertion of chest tube. More than 200 ml blood per hour over 3 to 4 consecutive hours. What is cardiac tamponade? The scenario is stab injury to chest wall interior on left side, hypotensive, neck veins engorged, heart sounds muffled. What is the diagnosis? What is the management? And so these points or clues are given in the scenario that there is a stab injury to the chest wall anterior on left side and the patient is hypotensive and the neck veins are engorged and the heart sounds are muffled. What is the definition of cardiac tamponade? It occurs mostly in penetrating thoracic trauma, especially in wounds parasternal region anteriorly and between two scapulas posteriorly. 75 ml of blood accumulation impair cardiac feeling resulting in tamponade and obstructive shock usually. Fast focused abdominal sonography for trauma. These are the investigations that are done for the cases of cardiac tamponade. That is FAST, which is stand for focused abdominal sonography for trauma. Then radiograph or X-ray are taken. It will show increased cardiac shadow. Then ultrasound is done. There will be fluid in pericardial sac and central venous catheter is done to check for rising pressure, ATLS circulation. Now, what are the treatment options for cardiac tamponade? These are needle pericardiocentesis is done for the aspiration of mm of blood. Then resuscitation is done to increase preload. Can buy some time to move to OT. Then connect immediate treatment, that is operative sternotomy or left thoracotomy is done with repair of heart in the OT. These are the managements for the cardiac tamponade. Now coming towards the arterial disorders, we have acute ischemic limb. We are having the scenario. There is a patient of 55 years having MI and develop atrial fibrillation or medication for atrial fibrillation. Severe pain in right lower limb. On examination, leg is pale, pulse is less and BP BP is 110 by 80 mm of Hg. What is the diagnosis, investigation, and management? So first, define the definition of acute ischemic limb. Any sudden decrease in the limb perfusion causing a potential threat to limb viability and is usually caused by thrombic or embolic pathology. So clinical examination is performed to confirm the diagnosis. First of all, check the temperature of the limb. Cold may be warm by reactive hyperemia. Sensations are usually absent. Integumentary changes of the skin, loss of hair or dorsum of toes, foot, thickening of the and toe due to slowed keratin turnover. Arterial occlusion is present and it is pallor and diminished, and paralysis is present, and early skin molding is present. Now investigations are done. What are the general investigations that are done, and what are the specific? In general, we will do the FBC, SR and platelets, the plasma fibrinogens, the protein electrophoresis, blood and urine glucose lipid profile, ECG and exercise test is done, radioactive isotopes and ventriculography is done, then chest X-ray and pulmonary function test are done. What are the specific tests that we will do for the case of the acute ischemic limb? We will do the Doppler ultrasound, that is flow detection. Then we will do the duplex imaging. Then we will do measurement of claudication distance. Then we will do the angiography, that is then the digital subtraction angiography, and then ABPI, that is ankle brachial pressure index. Now what are the treatment options? We will do the emergency and treated as soon as diagnosis. We will provide the emergency treatment. Okay, so we have two types of treatment, that is general and specific. In general, we will tell the patient that walking is not harmful. Rising heads 2 cm will relieve work performed by calf muscles. Then adjustment of lifestyle, elevation of head and of bed, then exclusive encouraged and Burger's exercise, and stop smoking, especially with Burger's disease, and then reduce weight and care of ischemic food. These are the general measurements. In specific measurements, we will ask the patient to take the drugs, that is vasotherapeutics, clopidogrel for increased claudication distance, and oxypentyphylline, that is decreased blood viscosity. Then we will do the anti-diabetic drugs, and we will give the antihypertensive agents, for example beta blockers, and we will give the antiplatelet agents like aspirin 300 milligram TID. Then we will give the analgesics, both opiate and non-opiates. Then we will give the antilipidemics, atorvastatin. What are the surgical options for the case of acute ischemic limb? We will do the transluminal angioplasty, the intraluminal stents. Okay, these are the surgical options for the case of varicose vein. We have left some topics. These are the pre-op and post-op assessment, and the extradural or epidural hematoma, and tumor markers, and sebaceous cyst. This we will cover this remaining topics in our next video. Okay, so let's revise the arterial disorders. What we discussed the acute ischemic limb. We study the scenario, then what is the definition, then what are the clinical examinations performed to confirm the diagnosis, then what is the investigation options. These are general and specific. What are the treatment options? These are general and specific. In specific, we have drugs options, and then we have surgery options. So for now, I'm ending this video, and in the next section we will be discussing the remaining topics, and then we will cover our general subject. Thank you.